Okay, well, welcome everyone. We're very excited to have Dr. Costales present today. As you know, Dr. Costales is a CMO over at Access. She's a board certified psychiatrist based in Phoenix. Her training and education, BS in biology from Genesis College, MD from Georgetown University School of Medicine, psychiatry residency at Kane, I'm probably saying that wrong, at Mount Sinai, where she served as administrative chief resident. She's had just a really outstanding career. She was with Connections right prior to moving over to Access. She has deep experience in psychiatric crisis care, with psychotic disorders, personality disorders, addiction, postpartum mental health. She's an advocate for early intervention and community-based mental health services. And she's just been recognized and sought after for her leadership and been featured in Arizona Medical Association member spotlight series. And she's known for her contributions in strategic psychiatric leadership, including roles as faculty with open mind strategy and innovations. So with that, we'd like to turn it over to Dr. Costales. And the only question is, do you want us to ask questions during, or do you want to have us wait till the end? It's up to you.
I'm okay with everyone asking questions during the meeting. That's fine with me as they come up. If we need a part two, could we get a part two at some point? Is that okay? Okay, great. I know we have a lot to cover because there's so much going on at the agency. So thank you. And I'm actually I'm joined by a couple of my colleagues today from our legislative liaison team. David and Steve, do you want to introduce yourselves?
Yeah, absolutely. I know some of the people on the call. For everyone else, my name is Damian Carpenter. I'm the Chief Legislative Liaison here at Access, and I'll pass it over to our specialist, Steve.
Everyone, first time joining in for everyone here. So first time meeting everyone. So excited to be here. My name is Steve Berg, and I am the Legislative Specialist with Access. Thanks, Dr. Costales.
These guys are here to support me. You know, there's so much going on when it comes to federal and state government. It's a lot of activity, and they're going to be able to fill in a lot more details. So, Damien and Steve, I didn't tell you about this, but I put together some slides for your section, just high-level bullet points that, you know, we talk about all the time. And if there's anything that you want to add, please do that at that time. I'll get rolling. Let me just share my screen. I have some slides.
I'll keep the chat open and I'll monitor for questions as well.
Okay. Are you guys seeing a slideshow? Yes. Okay.
We're seeing the slides, but not slideshow.
All right, let me. How's that?
That's good.
All right. So Lori gave me the best introduction ever. I could never say those things about myself. So thank you so much, Lori, for doing that. I will start with an overview of our Medicaid system, just to give us some context, talk about the scope of our work, some of the history of the agency, and a little bit about how we're structured. Again, anyone has questions, I'm not going to pay attention to who has a hand raised, so just come off mute and go ahead and stop me because I talk a lot sometimes. So Medicaid 101, please forgive me if you already know some of this stuff. This is for a very broad audience, but Medicaid and Medicare are not the same thing. I oversee the Medicaid along with a whole leadership team in the state of Arizona. So we're a joint federal and state program. We provide healthcare coverage for people with limited income and resources. We, as a whole nationwide Medicaid system, serve around 80 million people. And our spend accounts for almost a fifth of all healthcare spending. So we are administrated by individual states. There are broad federal rules within which we operate. States end up having some flexibility in determining which populations and services to cover and how to deliver care, how much to reimburse providers within federal rules. And we can also seek Section 1115 waivers from CMS, which Damien and Steve are going to talk about a little bit later on in the presentation. But basically, we can seek these waivers to test and implement approaches that differ from what is currently required by federal statute. If the secretary determines that the waivers would advance program objectives. So it gives us that flexibility to try out some new things and cover some new services and maybe some new ways. Okay, so just a little bit of access at a glance. We are the largest insurer in Arizona. We cover over 2 million members. We cover about half of the births. Pertinent to our conversation
I'll do
today.
like one of my husband. I have one headphone.
So sorry, we have a nationally recognized behavioral health crisis system among Medicaid programs. I like to highlight that one because I came from working in the crisis system and worked alongside some incredible people who helped create the crisis system and help write at a federal level roadmap to the ideal crisis system. I cover 60% of nursing facility days. We have funding from federal, state, and county. So depending on what kind of program we're talking about, that funding can be rated in different ways. We have more than 100,000 registered healthcare providers, 11 managed care health plans that we contract with to deliver services. And we are the single state agency for behavioral health, state mental health authority, and state opioid treatment authority. So an interesting thing about our Medicaid system is that we have operated on a waiver since 1982, and we're the first state to operate under a statewide managed care demonstration, the only state to have done so from the start of its Medicaid program. So I'm going to talk a little bit about the history. We were the last state to create a Medicaid program. We were a holdout. I was giving a talk at some conference a couple of weeks ago, and I was talking about what it's like to work in Arizona as I was going through this history. And I said that the state motto maybe should be "Don't tell me what to do," because they were really not wanting to launch a Medicaid program. But I'm sure some of you on this call remember how that actually went. Okay, and then a few more things to highlight. So services for members with serious mental illness designation who live in Maricopa County were integrated under the Regional Behavioral Health Authority in the Central Region, which is currently Mercy Care, in 2014. And then also pertinent to our conversation today, in 2016, the Division of Behavioral Health Services, which is the mental health authority for the state of Arizona, was under the Department of Health Services, ADHS, and it moved to Access in 2016. So that move gave us that power to act as a state mental health authority. And I would be remiss if I didn't mention that we're scared about cuts happening to Medicaid. And that's happening right now. Just wanted to reflect how much our population has grown since 1985 of Medicaid population that we serve, a lot of people. High level, the way that I sometimes conceptualize our roles and responsibilities, we reimburse and we regulate. So we contract with the managed care organizations like Mercy Care, United, Community Plan, to provide payment of covered healthcare services for those members who are enrolled in those managed care organizations. And then we also work directly with enrolled providers for our fee-for-service enrolled members. And we do a lot of regulation. We oversee the Access Complete Care health plans to ensure compliance with state and federal regulations and our contractual arrangements. We oversee access enrolled providers to ensure compliance with our policies. And we are also responsible for implementation of a quality strategy to promote continuous quality improvement efforts to improve member experience and outcomes as well as cost efficiency. And I can talk a little bit about, I think right at the end, some of the things we're doing. What we don't do is anything to do with Medicare, really. Healthcare licensing, I always like to point that out. So licensing, anything to do with licensure of facilities, of providers, or of facilities is ADHS. Of providers, that would be with their respective boards, professional boards. And then we don't regulate providers, facilities who aren't enrolled with Access or receiving funding from Access in some way.
One question. So if there is a provider out there and they're not currently a Medicaid provider, but they want to be, what does that onboarding process look like? Is that like a 1 month, 3 month, 1 year? How long is that process?
So the last time I checked, it was for new providers enrolling, I think happening in under 90 days, pretty consistently. I remember when I enrolled, it was under 60 days. So I think sometimes there's some back and forth that can occur. If not, maybe all the documentation isn't filled in the right way, or not all the documentation is completed. But under 90 days is what we shoot for.
Thank you.
And then
And
Lori,
on
it will depend on the provider type as well. Like
Yeah.
high-risk providers are going to have more background checks than providers that are not considered high risk.
So yeah, you can see that detailed on our website too, all the different provider types that we have, and then the risk designation for that provider type.
do we have any potential, are they in the process of trying to fill the director vacancy?
I mean, I think always it's hard to say exactly where that's at. I'm definitely not privy to those conversations happening. That's the goal, certainly always is to get a director into that spot. Yeah, we miss Carmen. She's still around in an advisory capacity, which we really appreciate. But she's a great leader. And hopefully we'll have another director soon.
Okay.
I just wanted to give a high level look at what our leadership team looks like though, and how we're structured, that the director reports directly to the governor. And I had been reporting to the director prior to Carmen leaving. At this point, I'm reporting to one of the deputy directors, Kristen Chalcombe. And then the other deputy director is Marcus Johnson over here. I wanted to zoom in on the restructuring of our medical services team. So probably, let's see, more than a year ago, the agency had something like 1.5 physicians. So when Dr. Solik was here, she had like a part-time medical director on the fee-for-service side of the house, and of course a part-time dental director. But really that was it as far as physicians. And it's a lot of work that we end up doing. So she really paved the way for me to come on board. by restructuring, adding a lot of medical directors, adding physician oversight. And then they were brought under me. So all of the medical directors are now reporting up to me. And then for the managed care side of the house, we subsequently, I think in April, moved the quality management and quality improvement departments under Dr. Shinar, which reports up to me. So we're taking a new look at the role that physicians play at Access, and specifically in inserting our roles into a lot of the quality management processes in the hopes that this will help all the efforts that we have, which again, I'm going to get into right at the end, all of our efforts to improve the quality of service throughout our system. And so this is a big first step, is this restructuring. A lot
Do
of
we
changes
think-
to see.
Do you think that the restructuring will also help streamline so payment for providers' services will be faster than it has been lately?
The goal is definitely to make it faster. I will tell you that. I don't know if I'm trying to think if this specific change will have that kind of impact, and probably not directly. I can imagine that having an indirect impact because a lot of what we're doing is working on all of the processes and procedures related to the administration of healthcare here. So really, a lot of us doctors are spending a lot of time meeting, and our agency is big. It has a lot of people working on it. I still don't even know all the projects happening and all the teams. So we're spending time as physician leadership getting to know all of the teams and hearing what they're doing, and then trying to see where we can make the most impact. And certainly having an impact in a lot of those policies and procedures that you wouldn't necessarily connect us to directly on the surface. So yeah, that's the goal.
Okay.
So like I said, we have 11 contracts with 8 unique managed care organizations. So we have our ACC line with 1.8 million members. We have our 2 REBAs, Mercy Care and Arizona Complete Health. We have our Altex, Arizona Long-Term Care Services for the elderly and physically disabled. And then we have Altex for DDD enrolled individuals. We also have the DCS Children's Health Plan, which is subcontracted out to Mercy Care. That's for children who are in DCS custody. And then we have our whole fee-for-service side of the house. So our American Indian Health Program, Tribal Altex, and that's been a hot topic and hotbed of activity for the last few years. So definitely a lower amount of members there compared to what you see like in our Access Complete Care plans, but a lot going on in that space. I think I can pause here. So I just wanted to start maybe federal, if that's okay with you guys, and then I'll shut up and let you talk.
Yeah, thanks, Dr. Costales. Do you want to take questions before I start? I'm not seeing anything in the chat, so I can start if you'd like.
Yeah, go ahead, unless anybody has anything they want to ask right now.
Perfect. So a lot of people probably saw in the news the Senate passed their version of the Big Beautiful Bill. Just an overview of that bill and where it's at, and provisions that pertain to Medicaid. There are work requirements in that bill. There are more frequent Medicaid eligibility checks in that bill. There's some reforms on provider taxes. And if you hear that word provider tax in Arizona, we call that the hospital assessment. And it's used to draw down, it's used kind of in coordination with the state match to draw down additional federal funds. And that is for they're trying to pass this bill before 4th of July. That is the president's goal. So we'll see what Medicaid provisions are kept. It could be amended further on since it's going back to the House. Lori?
I just want to clarify. So the work requirements are not intended for people with an SMI designation or with a disability, but those that are able-bodied, however you want to define that, and they happen to be on Medicaid because they're indigent. Is that the differentiation?
Are you asking me if the federal work requirements exclude people with an SMI?
Yes.
I need to check and see how it aligns because, as you know, that our state, Arizona, we have a work requirement as well. Our state work requirements that we've submitted to CMS would exclude SMI. I'd have to check on what the current version of the Medicaid work requirement includes. I know the Senate did kind of bump it down to younger people younger able-bodied adults would have to abide by the work requirements.
Okay.
Hear that? Yeah. Well,
And do you think that as far as the reassessment, does that mean people that have been determined disabled have to go through constant reassessments?
If you're referring to the eligibility checks, a
Mhm.
lot of checks Access does them annually. And I believe the current federal proposal is we'd have to do semi-annually or quarterly.
Well, I guess they can cut back the number of enrollees by both of those methods.
That's where
Unfortunately.
they are getting they are trying to reduce the deficit. So a lot of those big numbers that you're seeing with the Medicaid savings are from just smaller Medicaid rolls because of the work requirement and because of the more frequent eligibility checks. And then we can go to this next slide if you like, Dr. Costales.
I don't know if you want to hit on this at all right now, just the CMS rescission of guidance on health-related social needs, and then the designated state health plan and DSIPs. Or I can talk about it too.
You can go ahead if you'd like.
Okay, sorry. This is my slide that I put together for the Arizona
I'd have to
Psychiatric
defer to that.
Society. Yeah, I'm sorry. It's wordy too. So, there were a lot of changes with this administration that have been proposed, tossed out there. One thing that we did see was that on the HHS website, pretty early on, there was rescission of guidance on how states could address some of these not traditionally covered needs related to social determinants of health. And so what we were anticipating as we saw this occur was that if we had new requests or requests to renew existing waivers that we have to provide these services, coverage of these services, that it would likely not be approved moving forward. So the impact that we would likely see very obviously is in our targeted investments program and our housing and health opportunities program, which is H2O, which just got going. In reality, in October, I think we've been able to house something like close to 50 SMI members at this point. So there are definitely going to be some changes there. I don't think we understand the full scope of what the changes will be right now, Damien or Steve, unless you think otherwise. No.
Do you think that they will unhouse the 50 you housed, or they will just stop doing additional members?
Yeah, it's so our current waiver, like the H2O waiver, it really does provide just like 6 months of housing and then some support thereafter. We have a pretty extensive housing program otherwise that is state funded. So there's maybe some other opportunities if you're looking at like, community living placements, permanent supportive housing. Those are state funded, so they don't rely on federal funds. Damien, we're going to say something.
Yeah, I was just gonna say, I would assume that people that were seeking the H2O services they would have to go on the wait list for the Access Housing Program.
Yeah. To be like,
And is the wait list still 6,000 or 7,000?
Yes.
I'd have to check. Last I checked, I thought it was 3,500. It may have went up though. I know it's a big list, unfortunately.
sorry, was there a question?
No, just what is the housing wait list? But
Yeah, Damien,
Yeah.
would you mind just, I don't know if you
Yeah,
have access to it, and I'll keep
ABC and
going.
Home Inc. used to have a dashboard. I can look for it really quick.
Okay. All right, I'll keep going while he looks for that. Okay, so we kind of talked about some of this already. So the Access Works waiver amendment, which was something we had to submit back in, I think 2015 was when the statute was passed. We haven't actually had to implement any work requirements. It had been decided on a federal level, but obviously things have changed now. Certainly in our waiver amendment, which I think is still under review by CMS. Is that right, Jamie? Yeah. The SMI population was definitely excluded from our work requirements. We did not include them in the able-bodied adults group that we put together, but if there were federal requirements that contradicted that, federal requirements would supersede our state requirements.
I have a question on that. What about people who have an emerging illness that's not, diagnosed yet? Because, think about people with schizophrenia and prodromal stage seeking help and having a hard time with employment. Is there any way to document like that they're, in the pathway for help, or do they have to have a diagnosis, or how do you think that'll be interpreted?
So I have no idea that what's going to happen at the federal level. I can tell you that we would figure something out if it were just left up to us as the state. But Damien, did you have something to add? Sorry, I saw you moving on the corner of my eye. I will tell you that we haven't gotten that far.
Question.
Contemplating that kind of scenario. And we're gonna have to wait and see what the feds come out with.
I was just gonna say, with our Access Works waiver, I don't think they will approve it until after the bill is, because they need to see what the federal
What the
requirements
federal, yeah, okay, that
Yeah,
makes sense.
typically when they do that, states have to send an amendment to prove that they're in compliance. We'd have to send them our implementation plan.
I don't know if you can hear me. I was going to ask a question.
Yes,
Can you?
We
Yeah,
can,
this is Mike Franzak. It sounds like that work requirement is going to have a big impact on what are called the general mental health substance abuse population, which is probably the largest population in behavioral health. But it may not affect the SMI population.
Yeah, that's a good point. I know our state one has a carve out for people with
With
substance abuse
SMI.
with
Yeah.
SMI, and it also has the Gen Sud population. It also has people actively receiving SUD treatment. They're exempt as well from our state one, but um, the the federal work requirements they don't have as many carve outs as we do,
Yeah.
unfortunately.
Yeah, there's a fine line between some folks with general mental health and SMI. And of course, a lot of folks with substance use disorders are not working as well. But okay, thank you.
so where do we think I mean, let's say they lose all of they're not working and they lose their Medicaid because they're not working. They're still going to end up getting sick. They're still going to end up in emergency rooms. They're still
That's
going to
right.
end up overdosing. So who's going to pay for all that care if they're not on Medicaid? State only?
Right. Yeah, that's a great question. So it would, I think a lot of the cuts at the federal level are intended to shift cost to the states. Whether or not the states are able to provide the funds for those increased costs is another matter. I think we can confidently say if when people fall off of Medicaid and they don't have any other health insurance and they get sick and they end up in the emergency room, uncompensated care goes up. And so the states can find different ways, non-Title 19 funding, right, to compensate hospitals, emergency rooms, crisis centers, other providers for that care that is provided from state funds. But if at some point those funds will not be enough. Damien, do you think that was unfair of me to put it like that? You can keep me
No, I
honest.
was just going to add that's why you see the hospitals. I mean, the truth is also that uncompensated care is going to skyrocket. So the hospitals are going to be eating a lot of those costs as well, which is why all the big hospital associations are like staunchly opposed to all these proposals and advocating at the federal very, very hard.
Yeah, it's not a good situation when that happens for anybody. So I'm looking at the time and I'm wondering if, I feel like the IMD waiver is a big topic and I'm wondering if we can save it for the next time so that we can have an expanded conversation about it. Do you think that would be okay? So there's a lot to discuss there.
Hey, Josh, what do you think?
Josh, is that okay?
Yeah, I like the idea of spending some more time rather than something that's
Okay.
truncated, so let's do that.
I don't want to gloss over it. Okay, I appreciate that. I can put something together after this that's more extensive and send it to you guys.
Great.
Can you
Mhm.
talk about secure and where we are with
Yes.
secure residential?
Absolutely. Where are we? I mean, Damon, you can just start talking about it. I think it's on the next.
Yeah, I have it on my state budget bill slide.
There we go.
So there was funding for secure berths in the state budget bills. Some of the funding is the leftovers from the original SBIRF monies, and then some of it pulls from the SMI Housing Trust Fund. In terms of the timeline, there's a requirement for an implementation plan report that Access and ADHS does. That's due by February. And I believe we must publish the RFP by May or March. I'd have to check. I'm sure our team will be working on the RFP as we're working on the report as well. But it's going to be 5 million is the combined monies that we will be releasing in the RFP. And I'd be happy to take any questions.
Yeah.
Damien, I have a question on the, just looking back at that $3.5 million that was arranged several years ago. Where is that? Where are those funds?
So those funds are part of this new appropriation for SBIRFs. So we had original SBIRF money, and then we released an RFP. We had a bidder, we had a vendor that was constructing it. It was during COVID. We were running into a lot of barriers and problems. So we had to issue a stop work order. And then we got those monies back. And then we were trying to we were going to release the RFP, and the Title 13 population was inserted into the language, and that kind of delayed the process. And so now this will be our third attempt at getting the monies out the door.
Okay. So
that 3.5 is gone now and moved into this 5 million. What's the procedure? Where can we track that? Where can we follow that in the bills or how that happened?
Yeah, so if you go to JLBC's budget bills appropriation report, it says 3.5 IGA, and that's the indicator of that it's from those funds. And then it says 1.5 of SMI Housing Trust Fund. JLBC will be releasing an appropriations report in a couple months, and that will give even more detail, but that will spell it out. I know that the 3.5 is the original. That's why they called it the IGA fund, because it was IGA from the bill in 2018 or 19. It originally appropriated the money to the Department of Housing, and then they IGA'd it to us.
Right. Yeah. Okay. All right. Thank you.
Another question. In preparing the RFP, to what extent might you be getting community input from people like us at ACME or other people in the community?
Yeah, that's a great question. I think that's why the implementation report language was incorporated into the bill. I can put the bill in the chat and it will hyperlink to, it's a very detailed implementation report that we are going to have to develop. And I'm sure we're going to be using stakeholder feedback in developing those recommendations. And I'm sure Dr. Costales, if you want to speak about that, as I'll get the bill language right now and I'll put it in the chat so everyone can read it.
Yeah, so that report should be used as a plan, right? It's all of the things that we need to be considering, getting input on to make this a reality. And something I was going to get to later, but even it's coming up now, is we have a renewed interest in obtaining external stakeholder feedback and input on a lot of what we do. So I think as an agency, we're spending more time talking to, I mean, certainly other agencies, but providers who are out in the community directly, working with advocates. I think I spend a lot of my day talking to advocates and planning and communicating. So that will absolutely be part of the process.
I would encourage you to have a special place for family members who live with these terrible illnesses, psychosis, schizophrenia. Getting input from the families is just, I think, imperative. I hope you'll do that.
Yeah, I mean, yeah, absolutely. I mean, I think anybody who's worked with me when I was on the provider side knows that my work with families was incredibly important, and that when I came here to work in the SMI system in 2019, I was really disappointed overall with what I found. It was not what I had imagined it to be, and a big part of why it was not what I imagined it to be was that missing element of getting the family involved in care, and making them a part of all the decision making and planning. So that's something that's very important to me personally, and an agency priority as well. So Lori, did you have your hand up?
Just maybe what I see is that a lot of our agencies, whether it's Mercy or Access or others, have fully embraced hiring peers as part of the R&V SAR and building up that peer. But what I don't see in those agencies is a big effort from either people with SMI or their family care members. You have people that are recovered enough to work at an agency. So to me, that seems like it's a bit biased or skewed a bit. So I want
agree.
to make
I
sure
agree.
that you're really seeking out that voice, because again, your agencies are full of peers that have recovered.
Yeah, I think that that's one of the big benefits of having me in this position at Access, is that I was just working on the provider side for years, and I saw very firsthand a lot of the biased input, and it's important input, and it has its place, and it's not everything, and so absolutely, that's.
And Doctor, Dick made a point about involving families that have been dealing with this. I'd also encourage you to involve the group that saw the need for this, imagined the solution, drafted the legislation word by word, brought in police, fire, screening agency, evaluation agency, law enforcement, the courts into meetings for years, lobbied the legislation, got it passed, went through all the RFP stuff, got extra laws passed, has fought for this for 7 years, and then just got SB 1604 passed. I'd really encourage you to involve ACME in the thing that we've created legislatively. And there have been points along this road where we have been excluded, and I don't think the outcome was great, because this is a thing that we imagined, created, drafted, lobbied, and it's here today because of it. So I'd ask you that ACME be involved in these kinds of things, and the implementation plan moving forward. Question for you though, who drafted the implementation language? Do you know the implementation plan priorities 1 through 10? Do you know who drafted those?
So we had input into it. That I personally had input into some of those items, was answering questions. As far as who actually drafted it, governor's office, is that right, Damien?
I'm not sure. It happened
Okay.
quickly in the cage. They were negotiating on whether to include it or not, and as far as I know, that was just a compromise to include it.
Yeah. So in particular, we'd like to be included on discussions of it, because the language says that RFP's got to go out by what, May 1st, June 1st,
Yes.
whatever the date is.
May 1st.
But what if it comes back and it says, well, actually, it's a violation of Olmstead? You're going to put out the RFP if it's a violation of Olmstead? I don't think so. So, and from our perspective, this has been discussed for 7 years at the legislature. It's clearly not a violation of Olmstead. This is why we'd like to have our voice considered, because we saw this language, and having been around this one issue for a very long time, almost a decade now, what there's been from a bunch of different agencies, or the executive branch has been barriers thrown up. I feel like the access is different now, and we're excited about everything that's happening there. But from the executive branch, there's been a lot of barriers thrown up, and it feels like, and your comment about this being a concession makes me feel even more like this is the case, that this is at least number 10 and a couple more in there are there to stop this from happening. And so we'd like to be involved to make sure that it does happen.
Part of the reason it's so important for us to be involved is we're focused on the chronically mentally ill, many of whom are so ill they don't know they're ill. And we try to be the voice for them so we can help balance things out vis-a-vis those who, the peers and others who, many of whom believe that everybody can fit into their category. And many of those who are very chronic, perhaps with the type of treatment we recommend, could become a part of that category. But we have to properly attend to the more severely afflicted to find out which ones can, and then to help as best we can those who really have a tough time fitting into the kind of the mainstream category.
Yeah, yeah, no, absolutely. And I mean, I think I have a pretty clear picture in my head of who needs SBIRFs, not like would benefit from, needs an SBIRF. There are a lot of patients that I treated had connections, or prior to that when I was in the SMI clinics, and especially when I was at Connections, I knew as soon as I discharged them, it was likely to fall apart, and it was a terrible position to be in, and to see them come back in, and like that's the best case scenario, that they come back in, right? Because that means they're still alive.
Yeah.
That means they're still alive and they're not in jail. So to be able to stop that cycle for people is immensely important to me.
We really appreciate that. Thank you.
Yeah.
That's good to hear.
So one thing, question, with someone with your experience, and you were like right there on the front lines, and you could see if you let someone out that became voluntary all of a sudden at Connections or whatever, and that they kept coming back in. Do you have the governor's office? Are you having conversations, giving them kind of real case scenarios of, as psychiatrists working in this area, that secure births are not trying to lock people up. Secure births are trying to save people, give them some time of stability to get insight, and then hopefully step down at some point in the future. Are you having those very real conversations, and are they being accepted?
Yeah, those of you who know me know that I'm not shy to share my experience, and yeah, they've been receptive. The people that I've spoken with at the governor's office, because it's hard. It is when you're not in it and you don't have experience treating this population or working with this population, or have a loved one who's part of this population. It's hard to imagine. It's hard to conceptualize what we're even talking about. It's hard to conceptualize someone who is that mentally ill. So those stories are very important.
Yeah, one other point I think you want to consider when you're talking about implementation is why the first effort failed. Because we proposed something while I was with COPA and found that it was hard to get property that was large enough, all of the requirements. The amount of money was not sufficient to actually create the program, because we were going to do 2 of them. So you might want to think about why the first effort failed in your new plan.
Yeah, that was definitely something that we've been talking about. I think probably for months now, trying to understand, looking back, seeing what happened last time and trying to learn from it.
Great,
Point taken.
good.
When do you expect the meetings to begin on the implementation plan?
Is it mid-July, Damien, that
We start forming work groups. I start sending everything out in mid-July. And then our internal team will start developing work groups to implement these bills. But in terms of our public stakeholder meetings, it would be a couple months after that. You know, we have to meet internally first and start
getting our ducks in a row? Yeah,
Can we be involved in one of the work groups?
yes.
Now, when you talk about this
Stop me.
implementation plan, and are you saying that that implementation plan is for before you do the RFP and make sure that the bidders are going to adhere to the plan? What if someone else, since we have the laws on the books now, goes in and gets a secure birth license? How does that overlap with your implementation plan for the money that's allocated from the state? Does it have anything to do with it, or is that totally separate?
That's a great question, Lori.
But I mean, one thing is we are working, ADHS is a close partner, and they're the ones who are would be issuing the license. In order to be enrolled as a provider, let me think through that.
My understanding is anyone could go get an SBIRF license right now and go build their SBIRFs. This is just for the
Did they
RFP.
roll out the licensure type? The separate?
Yeah.
They did already? Okay.
Yeah.
But part of the implementation report is to look at that licensure and to look at access policy to see if it needs to be revamped
Okay.
before we release the RFP.
The revamping. Okay. Yeah.
So it's tied to the state money.
Yeah, exactly. They can build it if they pay for it themselves, I suppose.
But then
if
if
they
they
have-
have to roll with us as the provider type, they will have to
Lori
adhere
brings up a
to.
good, Lori brings up a good point though. If we're opening up the rules and policy and someone comes in tomorrow before we do it, what would that look like? So that is a good point, something to think about.
And I think that, again, this was a last minute backroom negotiation right before so I think a lot of these things, to say that it hasn't been thought about, we had some of the brightest minds in the Valley working on what this needed to be, how it needed to look. And we carefully worked on it for what, Josh, a year or more down at the Capitol with everyone and experts coming in. So it's not like it was thrown together and things were left out. I think that if we're trying to bring another level of looking at it, I don't think it should get in the way of what's already been done.
No, certainly not. I think, if we look at the last RFP, a lot of that was not considered at the agency.
Yeah. I can again, just coming from the perspective of the group that created this thing, and we created it for a population that we were living with, dealing with every day. It's just to be blunt, I'm very concerned about this process, and that there's something that could go out and be implemented, and after the passing of 1604 was ready to go. And now we're going to end up with a lot more red tape because of this implementation plan. And the idea of secure birth from the very beginning was not, the magic wasn't in all the fancy bells and whistles, the magic of the treatment. It was that we needed a safe place that a person that was involuntary for treatment could stay for 6 months or a year. And so the magic was in the ability to secure the location, not in the fancy treatment. And so I'm really, really concerned, just to be blunt, really concerned.
I'm gonna push back against you.
A bunch of regulation that is unnecessary.
I'm gonna push back against one part of that. Our system is not doing well. Our behavioral health system is floundering, and it's largely floundering, I think, due to a lack of clinical standards. And we need to establish what those clinical standards are, because I think there's a lot of births out there right now who are doing okay, but it could be going a lot better, and we need to do better. I think that, and we need to go back to the drawing board, and that's some of what we're doing right now. Starting with, we're looking at different lines of service and looking at how we can elevate the clinical standards in all of those different settings, and implement it in a realistic way.
But
And-
Dr. Costales, do you think that the fact that the pay rates for the births have been the same for years,
Oh,
they're
that's-
hiring
That's
people.
part of the problem. Yeah.
Okay, so unless
Yeah.
you're going to change
Yeah.
the reimbursement rate
We are.
significantly, don't expect to have master level people working in the births as the tech, right?
I know, I get it. I will,
So
that
are you,
is
Dr.
part
Costales,
of the planning.
are you saying
Yeah.
that the clinical standards as the system operates now are not, and so going back in time, have not been appropriate?
I think they have not been adequate in order to allow people to actually get better. I think we need to, as a system, say, like, elevate the minimum quality standard.
But maybe it's a
felt
length
better.
of stay. Maybe it's a
It's-
length of stay also. They move them out too soon.
Yeah, I mean, we
If
would,
you look at our policy, though,
That's one of the
It's-
things in the SBIRC report too, is discharge readiness.
yeah, and like trying to define what discharge ready means, because right now, I know of cases where patients had been discharged prematurely and ended up back in the hospital. And we are currently also looking into data to find those patterns to demonstrate that what we're currently requiring is not prescriptive enough, right? We need to say, these are the types of treatments that need to be happening. This is the frequency. Those treatments need to be happening. This is what you should look for when you're considering discharging to a lower level of care. And this is maybe what a step down plan would look like. They're not doing it on their own.
But can you talk, I mean, I don't think most of the providers I know aren't saying, I think, let's say Joe should step down. They're saying Joe shouldn't step down, but it's the utilization managers at the REBAs, Mercy, I don't know about Arizona, that are saying they have to move out. We are not paying after Friday. That's the actual conversation that's going on.
No,
So
I know.
that
I know.
that has
But
nothing to do with clinical readiness. It's the fact that our regional behavioral health agencies don't
But
want to keep them there.
If we leave wiggle room in our policies and our contracts with those managed care organization, it gives them leeway to make those kinds of calls. So if we open our policies and say, this is the minimum standard, those managed care organizations that are contracted with us have to comply.
yeah,
I hope
we
that
would-
works.
yeah, so
It
I
has
think,
to.
no, I mean, I think if we were to look at, what are the top 10 reasons that the system is falling apart, and we would agree with you that it's doing worse than it's ever done.
Mhm.
Very, very low on the list would be the regulation. It's not the regulation. It's not the reason that the system's falling apart. And I think thinking that we can regulate or red tape our way out of the hole that they're in,
That's,
we would thoroughly disagree with you.
it's one part.
It's
It's
yeah,
one part.
It's one
So
very
one part is elevating the clinical standards through policy changes and regulation. Another part is looking at who's providing those services, which is kind of related. And then it's also looking at the reimbursement models, and does the reimbursement model support the level of service that we think our members deserve in these situations? And if it doesn't, then that is something that needs to change too.
I think we're just, again, we can put a period on this discussion, but we're very concerned that the new standard of regulating these things starts with secure birth and not everywhere else that exists in the system that impacts the 62,000, whatever number of SMI. The annual report is 62,000. Your presentation said something like 40,000, but that impacts a very small number of SMI individuals. I think I'm concerned that we're starting with the new regulation on that level of care. Anyway, what other questions do we have? I think we're over time, so
Yeah.
maybe we can leave questions for the
I'd like
next IMD
I'd like to
discussion.
I have a question. I was trying to type it, but I'm a slow typer.
Okay.
One of the things that's frustrating for me and my son, we've been in the system 20 years. He's been out of births, in a birth, out of a birth, the process 4 times, where he ends up out of it on his own, hospitalized, back in the birth. And that cycle, I don't see it as changing because he's less functional today than he was 20 years ago when the process started. But when he's out of the birth, that there's no step down where they still are getting monitored medications and at least one regular meal a day, or at least one meal a day, and some supports. They go from that all the way to they're taking their own medication, and if they want to go to a daily program or do something, they can.
It's
or
a huge like leap down, right? It's
Yeah.
not like a step
Yes.
down, right? Yeah.
Yes. And
Yeah,
so
I
that's what
agree.
I would like to see is if something in between where the medication is still
Yes.
given and monitored, and at least one meal a day, and they have like that peer or that person, that staff member that's monitoring them.
Yeah, and I think so in stage 2, that's the system gaps, and how to compensate for those is a part of this overall picture, because I agree completely. It's a leap down.
But that's why Dr. Franczak created the Lighthouse, was exactly that, that they could go from a birth, which is medical necessity and treatment, to a community, but it looks just like a birth, except they don't have to program all day, but there is staffing there to prompt. They make sure that they cleanse, that they eat food, that they sleep. That was the point of creating a Lighthouse. The problem is the reimbursement rates aren't sufficient enough to encourage enough providers to do CLP with staffing.
Yeah, Lori,
I think there's something else that you're leaving out, Lori, that's very important. And that is that the model that Dr. created also included that these people actually have a lease there. So they actually, this is a tremendous but not financial advantage that these people have then live in lighthouses, because they actually feel like they belong to that house, as opposed to the transitory nature of most community settings.
Yeah. By the way, Lori, one correction. I didn't create the Lighthouse. Families like you and Dick created that Lighthouse. I just listened.
Yes, that's true.
And but then you got it done. You listened,
Well,
and you
yeah.
got it done. And we really appreciate it.
I think you need Dr. Franczak also, his voice in some of your community sessions along with ACME. But Patty had her hand up and then Rachel.
Yes, Dr. Costales, I'm not sure if she's still on here. I just want to know what is the gap with the looking at what has been regulated already? Is it being done? Our experience is that it's not being done in these births, that people are just sitting around all day. They're not even taking a walk. They're doing nothing. And you know, we created a big fraud with the with the Indian Health Association just recently, because there was nobody that's going out and documenting what is actually being done in these births. So where does that responsibility lie in access?
So we share regulatory requirements over births with ADHS licensure. Licensure enforces their regs, and we enforce our regs and policies. And where some of the gaps are, I think, are in our policies. So that's kind of what I'm referring to. We say like treatment has to be happening, but we don't define what that looks like. We don't define minimum frequency. We're too loose with it. So I think in order to be able to elevate that standard and really hold the births accountable and be clear about what the expectation is, a critical component of that is writing those into our policies.
So is the staff there to actually go out in substance abuse? When we had treatment centers, I have had, basically they would show up if someone complained about something, someone would get out there and see what was going on. Is that going on with the births?
Yes, I can tell you, especially post-fraud, waste and abuse, there's been increased requirements. I have personally gone on site visits with our quality management team on the DFSM side of the house. Is it enough? No, not yet. We need to step up our proactive activities. We've been and we're structured as an agency to be more on the reactive side. And that's another thing that's going to have to change fundamentally, is that we have to be more proactive and do more of that. Because you're absolutely right. You have to be able to see what's going on.
People don't do what you expect. They do what you inspect. And that's consistent.
That's right. That's right.
Thank you.
So Rachel, you had your hand up, and Dr. Costales, since we've gone on for so long, after Rachel's question,
we'll schedule part 2.
Yeah. Mm-hmm.
Yeah.
Yep. Sounds good. And thank you, Dr. Costales, and also for being so responsive when I've had questions in the past. One of the things, as you know, someone who takes a lot of calls from struggling families, there's a really wide variation in provider.
Mm-hmm.
I don't know how else to say it other than some providers are really good, some are not. And the areas of room for improvement surround, I would say, clozapine, understanding of guardianship, and understanding of COT. Is there anything that Access is working on to help those deficiencies?
Yes, absolutely. So this was my last hot topic. So thank you, Rachel. Is SMI provider education. So there is incredible variability, and another component of that is policy work and regulations in terms of what we require, but it's also, there's an huge education component. And so that's something we're working on, all of these things kind of simultaneously, because we have to. Clozapine education has been in the works for a couple months now with Dr. Love, who I first connected via you. And so he's working on developing clozapine education for the SMI clinics and for the inpatient providers as well. And I'm hoping to actually use how we roll out that education for clozapine as a template for rolling out additional education in the SMI clinics, in the inpatient facilities as well, focused on all of those topics. COT is a huge deficit, the knowledge. The psychopharmacology, another huge deficit. Guardianship, absolutely. These are all things, and in terms of like what their responsibilities are, what their role is supposed to be. There's huge gaps, and we are fully committed to creating education, figuring out how to make sure everyone really receives that education, and I think that that's one step towards the system functioning better and reducing that variability.
Thank you, Dr. Costales. I mean, we'd love it if you come to every stakeholder meeting. We always have interesting providers presenting, but I think your insight and your experience is amazing and contributes deeply to what we're trying to achieve. Again, we just don't want to mess up our secure birth baby.
I totally understand that. And this has been going on for so long. And I imagine that it's like, okay, now is not the time to let it slide. So I can completely appreciate that. Please know that I have very similar thoughts and feelings to all of you about how this should go.
That's good to hear.
Thank you, Doctor. Thank you,
Thank you.
Dan.
Thank you.
Thank you for
Thank
having
you,
me.
guys.
Thanks, Steve.
Thank you. Have a great evening.
Thanks,
And
everyone.
you guys were wonderful fielding our questions. We're now the easy group.
I'm looking forward to working with everyone during the interim. You know, I know we have a lot of work to do, so
So
thank
much
you.
work to do.
Thank you, Dan.
Thanks, guys.
Take
Thank
care.
you.
Thanks, everyone.
Thank you.
Goodbye.
Okay, so for those staying on now, I'm going to stop the recording as we always do during the family session.